I have the privilege of introducing our next speaker, Yutaka Tomizawa from the University of Washington. He's actually someone that I recruited before I left to come to Stanford to replace me clinically as a promise to John and Adomi that I wouldn't abandon the program there. And so Yutaka is doing quite well. He's a clinical associate professor of medicine at the University of Washington. He did his fellowship training, advanced fellowship training at the University of Pennsylvania, and actually completed a formal GI training in Japan before moving to the U.S. So he's got formal training from Japan as well as training in the U.S. And today he's going to be speaking to us on artificial intelligence to improve the recognition of gastric neoplasia. Yutaka.
Thank you very much, Joo Ha, for kind introduction. So thank you for inviting me to speak at this conference. So in my disclosure, so endoscopic detection, diagnosis of early gastric cancer remains challenging even for even us, and so especially for the gastroenterologist in the United States. This is because there are many reasons. One is the lesion reason, because of the lesion is very subtle mucosal irregularity, and oftentimes in the background of the active gastritis, plus minus atrophy, GIM. And also yesterday, many speakers talked about the quality of the endoscopy examination. As Joo Ha mentioned, as the gastroenterologists who are trained both in Japan and in the US, so I see quite different for the training of endoscopy in this country. So we do say see one, do one, teach one in the United States, especially in Japan, say see one, see one, see one, see one, see one, then maybe do one. So. There's a quite difference of the time of the spend for trainee to spend endoscopy. Also, I think importance of the trainer. So if we cannot provide high quality endoscopy for trainees, so trainee cannot learn how to examine. So I think the AI can help this. So these are the images obtained at the National Cancer Center in Japan, where the people underwent endoscopy for higher risk screening surveillance. So Japanese experienced endoscopists can detect and oftentimes characterize the neoplastic lesion on their examination, but this practice is has not been applicable in our country. So I think AI will help us to improve the level. So even the experienced endoscopists, they tend to miss up to 6% early recurrence in the screening endoscopy. So Dr. Chin He briefly mentioned about AI role for the modeling. So I think that's true. But this study was conducted by ASG AI Task Force to try to understand, what the GI community, so gastroenterologists, perceive toward the AI in their practice. So the majority of gastroenterology endoscopists thinks the AI is likely helpful, and then many of them think the AI as the diagnostic tool for like a computer-assisted detection and then computer-assisted characterization. So characterization meaning differentiate the neoplasia and the non-neoplasia. Also, if we see early gastric cancer, also important to where is the line between malignant, non-malignant. Also, how deep that early gastric cancer would be, is either submucosa or possibly even deeper. So we have currently several AI device platform, but many are more like a colonoscopy. So at least we have 3 upper GI AI device. One is in China and 2 in Japan. I think that maybe Korea may have. So, but not available in the United States yet. So this is the Gastro AI, so AI medical service, which I'm closely collaborating with Joo Ha and then Rob. So this AI, the hard drive, it can be connected with the endoscopy. So we can use the endoscopy freezer button and then, I'm sorry. Yeah, so like we use the endoscopy button, say, the AI say, oh, this is likely gastric adenocarcinoma. So the computer-assisted detection system was invented and reported first in 2018 in Japan. So they developed an AI system to diagnose the early gastric cancer. So they showed a sensitivity 92%. So subsequently, many studies to see the AI standalone performance for gastric neoplasia detection. So meta-analysis showed sensitivity 88%, specificity 89%. But these were just the standalone AI performance. So then subsequently, many groups in China and Japan, so they tested AI performance for comparing to expert endoscopist. So above study from China, so they test AI performance in real video examination. So they showed a higher sensitivity and then higher negative value. And then below study in Japan, so they used the pathology confirmed early gastric cancer, and then so they showed the AI was non-inferior to the expert endoscopist. But these are there's the standalone AI performance in video and then still images. So there are still rooms to improve the study design because we need to know the AI performance in real stomach examination. So the above study was conducted try to identify how the AI will be helpful to decrease the percentage of the blind spot examination. So when we examine the stomach, we clearly need to examine entire stomach. So with using AI, so they showed the decreased the blind spot area in the stomach on their routine EGD examination, and also with using AI, so the endoscope tend to spend a little bit more time to inspect the stomach examination, which is I think is important for good quality EGD examination. And then below study, so they tested AI performance for experienced endoscopists and they used the video of the subject who were known to have early gastric cancer, and so they did a test with and without AI. And so even among experienced endoscopists, if they used AI, so they showed a higher sensitivity of the detection, also disease characterization of early gastric cancer in the video. So most recently, so the group researchers in China, so they conducted a single center the randomized controlled trial with using EndoAngel AI system. So they assigned the two groups. The one group is the AI first examination and followed by routine examination. So, and then other group is the routine examination first and then followed by AI examination. So they did a crossover design. And then so they, the study protocol allowed the endoscopist to study protocol required endoscopists to do target biopsy from all suspicious lesions. So primary endpoint was actually the miss rate of the gastric neoplasia. So they concluded that with the similar inspection time with using AI, the miss rate of gastric neoplasia was significantly lower in the AI first group than routine first group. So that this group expanded this randomized controlled trial to multi-center control trial, and they reported, so they're also simultaneously examining, how the AI is good for real-time examination to decrease the observation blind spot area in the protocols. Reportedly, and this study is underway, so I think we expect some literature come out in near future. So for the advanced endoscopies, the AI can be helpful for disease characterization to differentiate, neoplasia and then non-neoplasia. This is quite important for the ESD practice because we need to see the clear demarcation line between cancer and non-cancer, and then we have to do the marking before we start some mucosal dissection. But this can be challenging, so we typically need to use some like a neo-focused magnification NBI mode, and then we sometimes use a water emulsion, and then we do the marking. So if the AI can help us for reduce the time and then more accurate marking, which would be helpful for advanced endoscopists like me. This is also the AI can be helpful for the disease characterization for the tumor neoplastic deep depth of invasion. So this is my ESD case early this year. So I was referring physicians noticed some like in antrum irregular lesion, so they took the biopsy and say high-grade dysplasia. So they referred me to consider ESD. So on the left images, my examination on the left images, so I clearly see concerning lesion, we see that elevator area and also some central depressed, some erythema, which is concerning for a deep invasion and with some erosion. But I clearly didn't see any absolute contraindication to perform ESD. So I actually performed ESD for diagnostic and then therapeutic intent. So the pathology came back, say, intramucosal adenocarcinoma, but at least some focal submucosal invasion, so T1B. But all the margin were negative for lateral margin, vertical margin, all negative cancer dysplasia. So I thought it was an en bloc resection was obtained, negative margin, so I thought it was a curative resection, but I raised this case to the tumor board, so multidisciplinary conference, so they agreed my assessment, so likely curative resection, so a patient is under surveillance endoscopy without any additional therapy. But if the AI could help us to more better characterization, what is the likely depth of this tumor before ESD. That is helpful for ESD practice because we can reduce the unnecessary endoscopy resection if the tumor is most likely deeply invaded. So the couple of the teams, groups tested that AI performance with this regard. So above study in Japan, so they educate AI to differentiate mucosa superficial submucosal invasion versus deeper. And then similarly, Chinese group in below said they educate AI to try to differentiate T1A, T1B. So both groups showed a similar data about a sensitivity is 85%, but we don't have many literature and study has been published with this regard. So if we see more study, this sensitivity 85% may change. So we need a little bit more data with this regard. So the AI. To develop the AI, so we need to train the AI system to detect the disease. So current available AI device was only for early gastric cancer detection because that is the usual practice in China, Japan, Korea. So they examine. So their practice is they examine and they can detect atrophy, intestinal metaplasia by macroscopic examination. So they don't do biopsy, they don't do signal mapping protocol. So they detect the target, they detect and lesion, then target the biopsy. But that practice is not widely available. It's not conducted in the United States. So our U.S. practice, usually EGD is performed for some diagnostic purposes. Oftentimes we do biopsy for H. pylori test. So then the gastroenterologist find the results of intestinal metaplasia. So oftentimes, gastroenterologists outside of this room in the community, they do or they may not be able to macroscopically recognize GIM in their routine EGD examination, and also when they detect the GIM, they are not sure how often they should examine. So these are the area I think the AI could be really helpful for our practice. So we did talk about the signal mapping protocol yesterday. So by definition, this is a biopsy protocol. Oftentimes, we do like a random biopsy. So the challenge is false negative rate. And so if we spend more time, so we, procedure, we need to see the balance in between our procedure time and then cost and also increasing the yield for diagnosed GIM. So as Dr. Morgan mentioned yesterday, ideally we do use the image-enhanced endoscopy, NBI, and then we try to see the GIM first, and then we do the biopsy rather than blindly mapping biopsy protocol. And then we did talk about OLGIM scoring system yesterday. Today, this is well known to be correlate with the higher risk of progression if the OLGIM stage is higher. But as many of you know, so it is not widely practiced in the United States because by definition, this is the biopsy required scoring system. So I think that AI likely help us in very near futures. One is the AI will likely assist us to first recognize GIM under white light examination, and then AI likely help us to, when we switch to the NBI mode, under NBI mode, the AI likely help where we should obtain a biopsy to confirm the metaplasia. And then ideally, AI will help us to determine OLGIM score even without biopsy in real-time endoscopy examination. So this is my proposed AI role and function in our practice for high risk gastric cancer screening in the U.S. population. So when we do white light examination, so AI raised the possibility, where the GIM and atrophy might be, and then AI alert us to switch to NBI. Under NBI examination, so then we can confirm the presence of the GIM, and then also AI help us to identify where we should get the biopsy, even for signal mapping protocol to increase the diagnostic yield. Ideally, if we have some like a magnification tool, so for in the US, Olympus scope, near focus function. So ideally, if the AI will display like OLGIM scoring system on the endoscopy monitor even without biopsy, that would be really helpful for better patient prognostication during the endoscopy examination. So I think this is what I'd like to see in near future with the AI examination in our endoscopy practice. So when we do examine a gastric mucosa under white light, so AI raised a suspicion for GIM, so AI alert us to switch to NBI mode. Under NBI examination, AI asks us to say, please close to the mucosa, closely examine the mucosa because there is the likely GIM. And then under close observation on the left side, and so AI may say, please do the standard biopsy and to confirm the GIM, or if the AI raise a suspicion of the early neoplasia, dysplasia, they may also say, please consider defer to expert endoscopists for consider ESD. And so if AI doesn't think anything for suspicious GIM, neoplasia, dysplasia, they may say, okay, so return back to the white light mode. So as I mentioned, so ideally AI help us to where we should obtain the biopsy to confirm GIM or neoplasia, dysplasia, and then ideally more prognostication. So with the image-enhanced endoscopy examination in real time, AI may, ideally AI help us to determine the OGIM score with some confidence, percent, even without biopsy. So this is just for illustrative video, which where I participate in creating the AI model with the AI company here. So this is I'd like to see in the near future our practice. So under white light, AI suggests where we should observe. Then they suggest GIM, so switch to NBI, image enhanced endoscopy. Under NBI, they more so confirm, oh, this is the area we should get the biopsy. So I think this will be really helpful in the U.S. practice in very near future. So in my conclusion, so AI used for diagnosis of gastric neoplasia. So standalone performance for detection has been supported. And real-time use has been evaluated in higher incidence prevalence region, and then also the data was very promising. And we need a little bit more data on lesion characterization, so margin, lateral deep margin. And so I think AI has great potential for real-time prognostication tool in higher risk gastric cancer screening in the US population. Thank you very much.